Hello, friends, and a very warm welcome to the next edition of the 4D session that we have, which is the detailed discussion and dialogue about Indian patients with diabetes. And today we have a very, very important topic to discuss because we're going to be discussing biomarkers, which is very essential not only now for diagnosis, but also for prognosticating, but also for trying to assess how our treatment is responding for a given patient. And I'm really lucky to have very esteemed colleagues today from the top-notch fields in cardiology, nephrology, and endocrinology joining me, answering some of the difficult but yet very, very practical questions that we are facing in our day-to-day practice. So with this very brief introduction, if I may introduce our panelists for today. And my first panelist today is Dr. Lijo Verghese. So he is a senior consultant cardiology. He's a professor and head of cardiology at KMCH, Coimbatore. I have known him from CMC days here in Vellore. And very warm welcome, Dr. Lijo. Really privileged to have you here.
Thank you.
Apart from cardiology, we have another good friend of mine from the endocrinology fraternity. We have Dr. Vidya Jahangir from the Kovai Medical Center and Hospital from Coimbatore. She's a consultant endocrinologist there, and we've been meeting several times, and really pleasure to have you on board, Dr. Vidya, today.
Thank you, Dr. Nathan, sir.
And our board would not be complete without a nephrologist, and we have with us a very senior nephrologist, Dr. Mangala Kumar from Kovai Medical Center, again from Coimbatore. A very warm welcome to you, sir, for the show.
Hello.
Great. So I think with our very esteemed panelists today, without wasting any time, we are just going to jump in to the topic of today, which is on biomarkers. And we're going to specifically talk about a few important biomarkers that all of us use in clinical practice. We use serum albumin. Of late, we also use a lot of NT-proBNP. We also use calcium, and we use obviously the glucose parameters to understand what's happening with the patient. Now, we all use these biomarkers from our own silos, being in endocrinology, cardiology, and nephrology, but our patient is the same. So let's try and join all the links. Let's learn from our learned panelists today as to how do we interpret all of these different biomarkers in our day-to-day clinical practice. And I think if I was to start, and maybe if I may start with you, Dr. Vidya, to begin with, maybe talking about one of the very important elements or electrolytes, calcium, that we often check in our body from an endocrinology perspective, but also in patients with diabetes. There are a lot of nuances about calcium. There is ionized, there's unionized calcium. In clinical practice, we do have, sometimes hypercalcemia. At times, we also feel that this is often missed, and many times, calcium is ignored, and later we tend to see very florid presentations of hypercalcemia, which sometimes are directly related to parathyroid disease, but can be, a lot different as well. So, Dr. Vidya, if I may start with you, and if you may tell me, all the different aspects of calcium in terms of the metabolic aspects, the hormonal aspects, and also the vascular implications, and how it really helps us in our clinical practice, especially in a patient who's common between cardiology, nephrology, and endocrinology. Dr. Vidya.
Thank you, Dr. Nathan, sir. I don't know where to start when it comes to calcium. It's between the endocrinologist and the nephrologist who use calcium often, especially in the setting of diabetes and chronic kidney disease, metabolic bone disorder setting. So calcium is one of the very commonly measured electrolytes, but sometimes we struggle to interpret it because in the context of why do we actually measure calcium? In an acute illness setting, we'll have to correlate it with the albumin. It has to be corrected to albumin because significant proportion of calcium is bound to albumin. So most of the time, sometimes we get called in an ICU setting or in a patient who's just recovering from acute illness on the ward. where they check the calcium, it's around 7.5, and they jump into prescribed calcium supplements or a big dose of vitamin D, and at that point it will be inappropriate. We'll have to correct to the albumin, which could be very low in an acute infection or in sepsis or in a patient who's malnourished, who's been in hospital for a very long time. So the reason why we check calcium, it should not be part of some random panel, a battery of investigation that we just do just in case. We should correlate it clinically. From endocrinology point, hypercalcemia is what we encounter in patients with primary hyperparathyroidism, where we have a high index of suspicion. We don't go in and check for calcium. Tertiary hyperpara, we seldom see these days because the nephrologists do a great job of managing hypocalcemia, vitamin D deficiency in the CKD setting. The hypocalcemia, we do come across at sometimes, but severe vitamin D deficiency causing hypocalcemia, we seldom see these days. But that's something we need to think about. Vitamin D deficiency or malabsorption, especially in children, that can present with hypocalcemia. Post-operative hypocalcemia, it's very important to monitor post-thyroidectomy or post-parathyroidectomy for hyperparathyroidism. When it comes to CKD and bone metabolic problems, at least in our corporate setting, the nephrologist usually prescribe the activated calcium and aim to keep it in the low normal range. So we'll have to make sure the PTH is not elevated 2 to 3 times the upper limit of normal, in which case there's a high risk of vascular calcification and risk of tertiary hyperparathyroidism. So we as endocrinologists do not usually interfere at a corporate setting where the nephrologists look after the calcium part when there is diabetes, CKD, and metabolic bone disorder. But this is something that we need to be aware of, and if it is not managed by the nephrologist, maybe we should gently highlight and take over the management. So those are the places where I think calcium comes into play. And in one place where we would not aggressively correct hypocalcemia is in acute pancreatitis. Sometimes we get called to ICU to manage diabetes because of acute pancreatitis. We do see significant hypocalcemia. Actually, in that setting, managing or correcting the acute hypocalcemia worsens acute pancreatitis. So we just have to refrain from correcting hypocalcemia, even if it is as low as 6, unless we see some kind of cardiac contractility problems. What do you think, Dr. Lejo? Do you have anything to add when it comes to that's one of the main reasons why we are reluctant to correct the hypocalcemia in acute pancreatitis setting? That's what I believe.
Yeah, sort of agree. I mean, hypocalcemia, at least from a cardiologist point of view, we do see quite commonly, especially in patients who come with multi-organ dysfunction. The commonest problem for us is, ECG change. Apart from the ECG changes, arrhythmias, and apart from neurological manifestations, arrhythmias is the most common thing that we see. But people don't actively, look for it. I mean, I can't remember the last time I've diagnosed hypocalcemia just purely based on ECG, because people just don't actively look for it. But I'm sure it's commonly there, especially in the ICU setting. So from my point of view, certainly it is a very important factor that needs to be kept in mind and actively treated. If not, can lead to life-threatening problems.
Completely agree. And Dr. Mangalakumar, your comments, you deal with a lot of calcium, hypocalcemia and CKD, don't you?
Thank you. See, the kidney plays an important role in terms of maintaining the 2 important electrolytes, calcium and phosphate, because when the patient with the CKD, the loss of synthetic function, which means we can't activate the vitamin D into an active form. So the absorption of the calcium from the GI goes down, so the people are prone to develop hypocalcemia. More importantly, the excretory function, when it goes down, we start retaking the phosphate, because the phosphorus is primarily excreted through the kidney. So these 2 things are quite important, because phosphate is a kind of silent killer, because retention of phosphate doesn't always cause major symptoms other than some skin manifestation. But with the same token, we don't see symptomatic hypocalcemia in CKD patient. They may be having, maybe it's because the coexistent acidosis is protected to some extent. But what's more important is this hyperphosphatemia because of retention, and hypocalcemia not only drives, it activates PTH secretion, absorption of the bone loss, but also contribute to the vascular calcification. Because that's a more important thing. Because what as a nephrologist will be worried about, not about the symptomatic hypocalcemia, rather be very cautious in terms of correcting the calcium, because by overcorrecting it or trying to normalize calcium, probably will be doing more injustice in terms of raising the calcium too much and causing vascular calcification, because the single most important factor contributes to the increased mortality of the patient. Of course, we have to correct, but not too much. Of course, we have to replace calcium, but not at the cost of causing worsening hypercalcemia as well as vascular calcification.
Thank you so much. I think that really completes the picture. We've seen the entire spectrum, right from hypercalcemia, be it PTH dependent or independent, as well as hypocalcemia, which could be either post-surgery or post other metabolic disorders. We looked at the arrhythmia aspect of it, the important role of the kidney, not only for calcium but phosphorus. And I think it is indeed one of the very important parameters. It should be monitored in these patients because many times, in practice, when I see a hypercalcemia, I may have a patient who's had several tons of reports done before and calcium has never been checked. We really don't know when this hypercalcemia really started. So yes, it is important. So let's change gears. We've been talking of calcium, and let's move from a cardiology perspective. Marker that of late has been really on the spotlight, the NT-proBNP, and of late, we all do use it very often. Very important in diagnosis of heart failure. But let's understand from Dr. Lijo the biology behind it. Why it really matters. How do we use it in clinical practice? What are the important modifiers? Let's hear about NT-proBNP from Dr. Lijo, and then would like to hear comments from Dr. Vidya and Dr. Mangakumar as well.
Yeah. Thank you, Dr. Nathan. So NT-proBNP is something which has come up in the last probably 5 to 10 years and really picked up in the last 5 years, especially in India. It's a very important biomarker, so to say, in the management of heart failure. Now, there are variations. Probably the BNP was the one which was earlier there, and then people have moved on to NT-proBNP. The main difference being the BNP has a half-life of 20 minutes. NT-proBNP's half-life is around 60 to 120 minutes. And where is it useful? Of course, apart from heart failure, that's the main diagnosis. It really helps, and not just in the diagnosis, it's more importantly helping in prognosticating. Now, what is the advantages? As I mentioned, it has a longer half-life. It has a higher stability compared to BNP. In the blood sample, it remains stable for at least around 72 hours, whereas the BNP lasts only for 4 hours. Any stress on the myocardium or on the atrial myocardium, the part of the muscles in the atria, will release the NT-proBNP. So it's highly sensitive, and diagnostic accuracy is quite good. So it provides a higher levels, resulting in a better differentiation between a normal patient and a patient with significant LV dysfunction or heart failure. It has a very strong negative predictive value. So by that I mean that if your NT-proBNP is negative, almost always you can rule out a heart failure. I'd call it very similar to what a D-dimer does for pulmonary embolism. So very high negative predictive value, and it also has very useful role in emergency setting. Let's say a patient comes to you with acute onset dyspnea. He's got underlying LV dysfunction. He's got a underlying COPD. So this is one of the initial tests that we do, especially in the ER. I mean, before a cardiologist involved, the ER physician itself orders, apart from the chest X-ray, ABG, echo, ECG. NT-proBNP is a very important part to find out how much of the LV dysfunction or heart failure is contributing to the dyspnea, apart from the COPD concept. So it really helps in differentiating. Even OP basis, a patient comes to you with dyspnea, and you want to see that, what percentage is contributed by, let's say, heart failure with preserved ejection fraction, as LV fraction is normal, then this really helps. And as I mentioned, ICU patients really helps in prognosticating. I mean, you can sort of say higher the value, more worse the heart failure, but doesn't really mean, but it's a prognostic value. It certainly shows that the patient is improving if the value is coming down over a period of time. And as I mentioned, it reflects the myocardial wall stress. especially on the atria, not just the structural changes, making it a very important tool in LV systolic dysfunction. And it has age-dependent cutoffs. So as you know, there's various cutoff depending on the age, and there's a cutoff based on the renal dysfunction as well. So there are limitations. Of course, one is, of course, the renal dysfunction patients. There may be a variation, but a significantly elevated NT-proBNP does signify a significant issue even in renal dysfunction. Lower levels may be observed in obese patients as well. So I would say this is something which has changed the dynamics in the management of heart failure. Something very easy to do. Report comes in a matter of 1 hour or 2 hours. Only issue being the other limitation or the other negative part of it being the cost. I think it's around 2,000 rupees as of now, but I'm sure it will come down in the near future. Thank you.
Thank you for giving us that in-depth deep dive on NT-proBNP. Dr. Vidya, any comments from your side from an endocrinology perspective?
So the NT-proBNP shows a dual relationship with diabetes. The higher levels inversely predicts the incident type 2 diabetes risk in a healthy individual. But as Dr. Lijo said, the elevated cardiovascular complications, the endothelial dysfunction, the left ventricular failure can also be predicted by the NT-proBNP. So elevated NT-proBNP reduces the diabetes risk probably via the enhanced insulin sensitivity, adiponectin secretion, and anti-inflammatory effects on the adipose tissue. The clinical utility wise, we could use it to detect asymptomatic heart failure, to stratify CV risk so that we can give personalized care, perhaps start SGLT2 inhibitor early on. But we need to remember that in obesity, NT-proBNP is slightly lower. So we'll have to interpret the value of the NT-proBNP in the context of obesity as well, because significant proportion of our patients are obese.
Agree. And from a nephrology point of view, is it a one-time NT-proBNP? It's follow-up in through the lens of dialysis? How would you place it, Dr. Mangal?
I think Liju mentioned earlier, the N-terminal fragment is excreted through the kidney. So when the renal functions stop dropping, you start accumulating. So the elevated NT-proBNP doesn't necessarily mean heart failure in a CKD patient. However, an elevated NT-proBNP is an independent risk factor for progression of CKD as well as increased cardiovascular mortality. That we have to keep it in mind. Second thing is it useful? Because the breathlessness, someone comes to your emergency, CKD patient, there are a number of reasons. It could be anemia, it could be metabolic acidosis, it could be infection, because these people, and it could be pulmonary edema, or it could be combination of all those things. So will it have any utility? Of course it will have utility, especially if we have the luxury of assessing in a serial manner. Because rather than having a snapshot with the serial rise, which gives a very good information in terms of patient is developing volume overload. Of course, most of the kidney patients, they're hypertensive, and the hypertensive because of salt and water retention, they are prone to volume excess. So it will be very useful. But we have to keep it in mind that as Liju already said, there is an age-specific cutoff. Similarly, we have an age-specific cutoff, especially when the CKD, when you're dealing with the different stage of CKD, we have to use a different cutoff compared to the general population to diagnose volume excess. So generally, if the young patients, young in the sense 50 to 700 picogram is acceptable one. In advanced CKD, you need to have proBNP of more than 1700. That's only that's the best level which will help to differentiate whether someone is volume overloaded or they have elevated NT-proBNP just because of the impaired clearance. Whichever the level, elevated NT-proBNP itself is a poor prognostic marker, because these patients are prone to develop a worsening CKD, a faster progression, as well as at the risk of increased cardiovascular mortality.
Absolutely great. So great insights. We've learned about NT-proBNP, its role in heart failure, but also looking through different lenses, through patients across different age groups, across different stages of CKD, across obesity, and how this can really help in diagnosis of heart failure and volume overload. So that's brilliant. Let's move on to our next biomarker for today, the discussion, and putting our nephrologist on the spot, talking about albumin. And I think albumin is something, again, which looks quite benign.
There's one more on NT-proBNP.
Yeah.
Should we finish that off? or
Yes,
there's
please,
one more?
please. Yes, please.
No, because there's one more topic on NT-proBNP. You want to finish off along with this the same time on the hemodynamic?
Yeah, if you'd like to add to it, yeah.
No, I mean, because we're talking about NT-proBNP, I thought
Yes,
might
yes,
as well finish that.
absolutely.
I mean, sorry to
Right.
interrupt you.
No worries, absolutely.
Okay, if it's okay with you, Dr. Vidya and Dr. Mangesh.
Yeah, sure.
Yeah. I thought because we are talking about it, I thought it'll be just a continuation. So I think, you can just probably start off that topic.
Yeah, please let us know about the hemodynamic, association of NT-proBNP.
Yeah, so just as a continuation of what we are discussing, now NT-proBNP, as I mentioned, it's basically directly tells you about the stress on the heart. So how does it work as a cardiac hemodynamic compass? Is basically it tells you about the volume overload status and the cardiac wall stress. So it helps you in assessing the cardiac filling pressures. So as I mentioned, this is released by the ventricles in response and the atria in response to stretch and strain. So it directly correlates with the stress on it and directly indicates an increased left ventricular end diastolic pressure. So this is a key measure of heart failure. There's a reduced ejection fraction in most of the cases. Of course, you do have the spectrum of heart failure with preserved ejection fraction when you have a normal LV function, and mostly it's a diastolic dysfunction. So the strain is more on the atria in this case, and you have a higher NT-proBNP. And again, this is associated with a poorer outcome. RV dysfunction also can elevate NT-proBNP, especially in a case of a pulmonary thromboembolism, or a PAH with RV strain also can have an elevated NT-proBNP. And as I mentioned, it has a real-time monitoring treatment efficacy. So in terms of your treatment over 24 to 48 hours, a reduction in more than 50 to 70% suggests a really good response to treatment, and it's a good prognostic indicator. So as I mentioned, it's a hemodynamic compass basically in these scenarios. So one is acute heart failure, hypertensive heart disease in ACS, some case of cardiorenal syndrome, and also with the pulmonary embolism as well. So these are the main scenarios where you can do this test.
Brilliant. Thank you so much, and also highlighting how not only for diagnosis but also monitoring response to therapy is something that can be really used from an NT-proBNP interpretation. Moving on further to our next biomarker, talking about albumin, coming from the liver, but yes, excreted through the kidney, and sometimes in high amounts. Sometimes just poor nutrition can change it. But let's hear from Dr. Mangala Kumar the basics of albumin, relation to CKD, and how do we use it in clinical practice.
Okay. See, the albumin level is quite commonly low, especially in patients with advanced CKD. There are a number of reasons. You can start with reduced intake, as well as number of patients with CKD. They have a coagulative liver disease and reduced liver synthesis, as well as increased loss. But the study shows, most of them it's observational studies, because we can't do an intervention study just replacing albumin. That shows it's a non-linear relationship between the albumin level as well as progression of the CKD, as well as increased hospitalization, increased cardiovascular mortality. The mechanism is it's very difficult to ascertain, because it's probably a number of mechanisms. Probably CKD is a state of generalized inflammation. Probably this it just denotes its inflammatory response, because we know that the number of patients when you get hospitalized, when there's infection or inflammation, the albumin goes down because it's a negative phase reactant. Probably the reduced albumin you've seen in a CKD patient reflects the state of generalized inflammation, because it's like a risk marker, like a cardiac troponin T. When you just see it's a chest pain patient comes with some elevated TROP, then you know that the patient is going to have increased risk of acute event in the next couple of weeks. The same thing in a CKD patient, low albumin, irrespective of whether it is reduced intake or increased loss, it just reports that there is a state of inflammation. And again, none of the other inflammatory markers like IL-6, it correlates with albumin. Probably it's something different. We do not know. Probably we need to learn more. But it just points someone that person is at an increased risk of adverse event.
Thank you for that. And again, going back to Dr. Lijo, how you would interpret albumin, especially in settings of heart failure.
Yeah, so albumin is something which compounds the heart failure treatment and diagnosis. as you know, low albumin is associated with edema, and heart failure itself will cause the same. So not just heart failure. So low albumin has a independent prognostic marker, especially in cardiology, in basically 2-3 fields. One is, of course, heart failure, even in ACS, and also in coronary artery disease. Now, it's again a prognostic marker in these patients. It's independently associated with outcomes in these patients. Why is it so? Because, of course, what Dr. Mangal Kumar said, it has an antioxidant, anti-inflammatory kind of role. So it increases the inflammation and the oxidatory stress, which drives plaque instability and atherosclerosis. So patients can have acute coronary syndrome, worsening heart failure. And the second thing is what I mentioned earlier, fluid management. Low albumin contributes to increased extravascular volume, which further worsens clinical heart failure and weight gain in these patients, and they're rapidly present with dyspnea. And it's highly difficult to manage these patients when they have a combination of both. And of course, it has some amount of anticoagulant properties as well. So even there is some association in peripheral vascular disease from the cardiology aspect. So the direct correlation of albumin is, as I mentioned, with heart failure, with acute coronary syndrome, atrial fibrillation to an extent, and in some extent to peripheral vascular disease also. Thank you.
A lot of story to tell from a serum albumin, but Dr. Vidya, your comments in patients with diabetes, how would you look at the albumin level?
In the context of diabetes, hypoalbuminemia is associated with higher insulin resistance, probably because of the shared pathways such as oxidative stress and inflammation. But you are the sarcopenic obesity expert, Dr. Nathan sir. So we know very well that diabetes promotes sarcopenia by inhibiting the muscle protein synthesis, and sarcopenia increases albuminuria risk in type 2 diabetic patients. And low albumin signals malnutrition is one of the markers for malnutrition or inflammation that could worsen muscle loss in diabetic patients. So that is something that we could look out for. Low albumin independently raises the infection-related mortality risk. Especially this has been very well described in COVID-19 during that pandemic, where diabetic patients who had very low albumin seem to have higher hospital mortality, complications like ketosis in acutely hyperglycemic diabetic patients. Low levels on admission signal worse outcome, and this has been very well described in the diabetic cohort. So those are the points I would like to add in addition to what Dr. Mangal and Dr. Lijo have explained.
Brilliant. Thank you so much for that addition. And I think continuing the discussion with you, Dr. Vidya, and talking about our next biomarker, which is about glycemic parameters. And for ages, we've been using HbA1c. Now with the coming up of CGMs, we all have been using a lot of CGMs as well. And we have other chronic biomarkers as well, which can be glycated albumin, fractosamine. But how would you place the real relevance and importance of these glycemic markers in a patient who's common to cardiology, nephrology, and endocrinology? Obviously, we've been focusing a lot on diabetes all along, and now we have broadened our horizon, and we do talk of how patients with diabetes is just not glucose, it is also their heart and the kidney, which is important. But talking back again about the glycemic markers, Dr. Vidya, how important are they? How do we use them in clinical practice? And talking about CGM specific as well.
Okay.
Yeah.
So traditionally, we were looking into fasting plasma glucose and postprandial and HbA1c. The HbA1c reflects the previous 2 to 3 months of glycemic control, but then there are some disadvantages with HbA1c, though it's the easiest blood investigation to request, which can be done any time of the day. It doesn't have to be in a fasting state, but then it's not really a good tool in certain conditions like where there are hemoglobinopathies or where there is anemia or during pregnancy, or when there has been a recent change in the patient's glycemic control, then it does not truly reflect how the patient's glycemic variability. For example, if the highs and the lows is not actually picked up by the HbA1c, it just gives a crude number that the control has been good or bad. So the HbA1c could be 8 and the patient could have low glycemic variability or very high glycemic variability, and the HbA1c simply does not give us an accurate answer. In order to pick up the glycemic variability, the one gadget we have is the continuous glucose monitoring. The situations where we'll come across high glycemic variability is patients who's got erratic meal intake, who's not compliant with diet, patients who are on dialysis and the blood sugars do fluctuate before, during, or after dialysis, or on a good day where they're not on dialysis, the blood sugars are slightly higher. On the days of dialysis, they can be low. There are various situations where we are not able to understand why the HbA1c is high despite the self-monitoring of blood sugars being normal, or why the self-monitoring blood sugars are high despite the HbA1c being spot on 6.5. And those are the circumstances where continuous glucose monitoring will be either real time or retrospectively looking into the data. We get a graph of what has been happening, and if the patient is meticulous enough to maintain a food diary, then we can correlate with what the patient has been eating and the activity log to see how we can help the patient either to change the lifestyle or change the medications, be it OHA or insulin. So the other markers that we don't use that often are the glycated albumin and fructosamine, which reflect the blood sugar control in the previous 2 to 3 weeks. In patients who have got hemoglobinopathies, then this is a useful tool. In CKD patients, as there's more uremia and creatinine and the patient becomes more anemic, HbA1c becomes an unreliable tool. I rely more on self-monitoring of blood sugars and CGM, which predicts or looks into the blood sugar control more meticulously, and we can alter the insulin doses depending upon the days of dialysis and the days of the patient is not on dialysis. It helps us adjust the dose of insulin much better. So CGM does have a good role, and most of the guidelines these days recommend using continuous glucose monitoring in all our patients with type 1 diabetes and type 2 diabetes, and is a very useful tool.
Right. Thank you so much for covering the entire spectrum. Yes, our practice has changed quite a lot, especially when we used to see a lot of high A1Cs with normal, fasting postprandial. Now we are able to find out what's actually going wrong, and the patients also are actually much more conscious when they're on a CGM rather than the days when they're not on CGM, because they know somebody is watching and this will be shown to the doctor. So they will definitely be more careful. And covered the importance in both from a cardiac and a nephrology perspective, especially in CKD. We are worried about low sugars than higher glucose values, and therefore again, monitoring is very, very important. So I think we've discussed the 4 biomarkers that we were here today, but in clinical practice, it's not one patient with one biomarker that we're often dealing. It's often combinations of these different biomarkers which throw kind of a puzzle to the clinician as to how you are going to go about it. And maybe I will request Dr. Mangakumar to take a couple of these combinations that we get in clinical practice, where there might be some kind of nuances with a high A1C or a low albumin and NT-proBNP. So maybe a few combinations I will say that we may see commonly in patients. I request you to comment, sir. So the first one would be a patient who's got a low albumin and an NT-proBNP which is gradually rising. How would you manage this patient?
See, generally in CKD patient, especially someone with dialysis or CKD5, we routinely monitor albumin. Because if you look at because there are any number of blood tests we could do it, there are very few blood laboratory parameters which will predict who is going to live long or not. Especially in advanced CKD, the number one is albumin, which is very important because low albumin is an independent risk factor for increased mortality. Another one is phosphorus. Very high phosphorus, they will develop calcification, they die. Very low phosphorus, they're malnourished and they will die. Very high potassium, they die hypokalemia. Very low potassium, they are not eating well, they die soon. So these are very simple tests will predict. But you mentioned that along with albumin and elevated NT-proBNP, which shows that they're not only malnourished, their cardiovascular mortality increases, they're also accumulating volume. Because the single most thing you could do in a patient with advanced CKD is addressing the volume status, because the sodium retention leading to volume expansion, leading to the heart failure and cardiac mortality. So if I see these patients, number one, they are in a state of inflammation. They are not only that inflammation increases cardiac mortality, but also they retaining volume and leading to hypertension, which will lead on to increased cardiovascular death. So what we do, find out what is causing it. Second thing is optimizing the diuretic therapy, whether adjusting the dose or going for multi-targeted therapy. Those are the things I would be looking at it. And of course, the simple things like correcting anemia is an important thing, because which will help with the cardiovascular function, and optimizing the antihypertensive therapy, and especially with ACE and ARB, because previously we used to think ACE and ARB should be stopped when the GFR drops 30. Now that stop trial, which clearly showed that we will stopping ACE or ARB in a patient with advanced CKD will probably contribute to cardiovascular mortality. So now the current recommendations continuing those therapy even when someone GFR drops below 20.
Brilliant, very succinctly summarized. Let's pick up another combination, Dr. Lijo, if I may ask you this one. And you had mentioned about this a little earlier when you talked of arrhythmias, or maybe specifically you see a QT which is prolonged, and along with that there is a calcium value which is low, and low calcium QT prolongation patient is already on some antiarrhythmics. How would you approach that patient?
Yeah, so it's a difficult clinical scenario where you have a QT prolongation with hypocalcemia and the patient is already on antiarrhythmics. So these patients have to be managed very carefully. Albumin again plays a very important role in this scenario. You have to manage the calcium, because as you know, the QT, as it prolongs, the chance of having a PF, VT, VF, torsades all rise. Of course, there will be drug interaction, especially with amiodarone. Beta blockers need to be given cautiously because of the QT prolongation. So in this particular scenario, you have to, there is no one particular drug which may act. You need to find out the exact cause for it. Is the hypocalcemia due to a systemic and metabolic cause? What is the exact reason for it? Correct it, and then see what can be done. Because many times just correcting that alone suffice, and antiarrhythmics need not be escalated.
Absolutely. So treat the hypocalcemia before jumping on to change the antiarrhythmics. Very well summarized. And maybe another combination, and this time may I ask you, Dr. Vidya, to comment. And this is in a patient who's got an abnormal calcium, maybe a high calcium value with a high PTH. Again, this is something said to be not so common, but we do see in clinical practice. And how do we approach this patient? Is the patient more at risk for the vascular risk? How we go about the diagnosis of primary hyperparathyroidism? High calcium, high pH.
Okay, so I would assume this is primary hyperparathyroidism rather than tertiary, as I said before, that tertiary we don't see that often these days because the secondary hyperpara is very well managed. But in this context of primary hyperparathyroidism, we just need to, make sure that the urinary calcium excretion is, is all right, to make sure that it's not familial hypercalciuric hypocalcemia. Another condition is just to make sure that it is not the tumor-induced, which is not very common that we see, but then we do come across as suppressed or inappropriately normal, low normal PTH in the context of high calcium. So if it is primary hyperpara, then the next step would be to try and locate which of these 4 glands is problematic, and most common is a solitary adenoma. Then we could do system B, and followed by either a CT or an ultrasound, depending upon what the surgeon wants, and then go for a minimal invasive parathyroidectomy, which would be the definitive treatment in a patient who's willing to undergo surgery and who's fit enough to undergo surgery. In patients who don't want surgery or not well enough, then we could use calcium mimetic like cinacalcet as a temporary measure. so that they do not develop the complications of hypercalcemia.
Perfect. So you've outlined the entire treatment of PHPT. Really like the point that you mentioned to rule out FHH, the familial hypercalcemia, hypocalciuric hypercalcemia, because that would be an important differential diagnosis. However, the calcium levels may not be very high in that case, but nevertheless should be ruled out. So great. I think with this we have covered most of what we had to. But before we let go our very esteemed panelists for today, who've thrown a lot of important, light on very important aspects of these biomarkers, I would request each of our panelists to give me a one-line summary for each of the biomarkers from their domains of cardiology, nephrology, and endocrinology. Maybe Dr. Mangakumar, I would start with you. One line about each of them, the albumin, the calcium, NT-proBNP, and glucose, from a nephrologist's perspective. For all our viewers who joined us, what would be your one-line message for all of these four?
I'll choose albumin because low albumin, someone is going to die prematurely. They got something is going on.
Right. So very, very important prognosticating marker, as you rightly said. And yes, so don't ignore a low albumin is what Dr. Mangakumar is telling us. So one line also of calcium, NT-proBNP, and glucose from a nephrologist's perspective.
Calcium metabolic defects common, but don't overcorrect it.
Right.
With regards to heart failure, NT-proBNP, age adjusted value has to be followed, but elevated NT-proBNP is a risk factor for worse outcome.
Brilliant. And glucose from a nephrologist's perspective?
Okay. Hypoglycemia harms more than hyperglycemia when advanced CKD.
Brilliant. I think that's a very, very important summary from a nephrology point of view, clearly indicating do not overcorrect calcium. When you're talking of glucose in patients with CKD, be worried of hypoglycemia more than hyperglycemia. And both albumin and NT-proBNP, bad prognosticating indicators if they're high, but at the same time, look at age-specific, GFR-specific values of NT-proBNP. Dr. Lijo, moving on to you, one-line summary of each of these four biomarkers from a cardiology perspective.
Yeah, so calcium, especially hypocalcemia, is something that needs to be corrected with direct correlation with arrhythmia and mortality. Albumin, as I mentioned, again has a independent prognostic marker for ACS, coronary artery disease, and heart failure. NT-proBNP is emerged as a really important tool, a screening tool with a very high negative predictive value in diagnosis heart failure and compared to other situations. And for me, HbA1c, in terms of it has a direct correlation with patients who come to us with ACS, patients who undergo a procedure, an angioplasty, and worse outcome for patients who undergo a CABG as well. And I'm yet to see a normal HbA1c, let's say, of around 7 to 7.5 even for a diabetic who comes with an MI. The average, we've done studies here, a first-time MI patient who's a diabetic or a new onset diabetic, average is around 9 to 10 HbA1c when they come with an MI. I'm yet to see a HbA1c of 7 in a diabetic who comes with an MI. So it has a very, very direct correlation with STEMI or ACS.
Very, very well said. And I must add to that not only during MI, and this is a nationwide study that I can quote, where 70% of the people living with type 2 diabetes in India don't have an A1C of 7 or 7.5. So unfortunately, despite having so many good medications, so many good doctors all across the country, we still are struggling to bring down the national HbA1c average of our country, and there are several reasons to that, but that's for another day. Dr. Vidya, your comments on these four biomarkers, the albumin, the calcium, NT-proBNP, and your very own glucose.
Okay, to begin with, albumin is a marker of nutrition, and a very low albumin, like the other doctors have mentioned, is a very poor prognostic marker. Infection, inflammation, sepsis in acute ICU setting, or even at the time of admission, very low albumin just shows that there's a higher mortality risk, even in the patients with type 2 diabetes. One thing I just want to add is that if you're going to use an insulin which binds to albumin a lot, like the longer-acting degludec, then we'll have to reduce the dose of insulin, because this could cause aggressive glycemic control with insulin that is longer acting like degludec can cause significant hypoglycemia. So we'll have to use an insulin that does not get bound to albumin. Talking about hypo and hypercalcemia, unless the cause is quite straightforward, like chronic kidney disease, we'll have to do a systematic investigations. The parathyroid hormone should be sent to the lab immediately. It should not be from a collection center. The phosphate ideally in the fasting state. And we need to interpret the parathyroid hormone levels in the context of the calcium to determine if it is a true hyperparathyroidism, and then investigate further once the diagnosis of primary hyperpara is confirmed. The NT-proBNP, yes, it's a useful tool, especially in diabetic patients, to pick up asymptomatic heart failure so that we can give a personalized treatment, for example, with an SGLT inhibitor, and to pick up asymptomatic heart failure in our diabetic patients who walk into the OP, then NT-proBNP is a very useful tool. CGM, we've been using that quite often in our patients. Is a very good tool in patients with high glycemic variability, which has been linked to micro and macrovascular complications. So HbA1c does not reflect the glycemic control in many of our patients, and in those patients where we suspect the HbA1c is not reliable, then glycemic variability could be detected with the continuous glucose monitor. And as you rightly said, sir, the patients who are using the CGM, they are a bit more meticulous in watching what they eat, because they know that they're being watched, and invariably we get better control in patients who use CGM quite often.
Thank you so much. That was absolutely amazing. Really want to re-highlight the point you mentioned about PTH sampling. And this is a very common pre-analytical error, where if it is not an ice sample, if it has been collected and then kept in the lab for a very long time, the PTH would disintegrate and you get a falsely low value. But yes, all the points very well taken. I think our audience have had a delight listening to all three of you today. Thank you so much for joining in and for taking us through the journey of these different biomarkers in this particular series of the 4D, that is the detailed discussion dialogue in patients with diabetes. So thank you so much for joining, and with this we'll sign off for today. Thank you so much.
Thank you, sir. Thank you.
Thank you.